Good day. I am Sherilyn Francis, and on behalf of the Morehouse School of Medicine's National Center for Primary Care and Hybrid Solutions, we welcome you to today's webinar. Additionally, we invite you to connect with us via social media using hashtag HIT Solutions Center. And if you see something today that sparks your interest, please feel free to live tweet, share, or post that on your favorite social media platform. I now present to you today's webinar entitled Clinicians Coping with the Impact of COVID-19, moderated by Dr. Dominic Mack and featuring panelists Dr. Aman Mangia, Dr. W. Steen James, and Mr. Amin Holmes. The objectives for today's webinar are to characterize COVID-19 trends among marginalized populations, to evaluate the barriers and facilitators to treatment during the COVID-19 pandemic, to assess the use of health information technology resources to overcome the challenges presented during the COVID-19 outbreak, and to discuss solutions to generate revenue for your practice. And now, Dr. Mack.
Thank you, Sherilyn. And in conjunction with the objectives, we'd like to welcome everyone today for taking your time to come on this webinar. And we've asked our panelists to speak with you about issues that may be facing practices out there, health professionals. What are the challenges that we're seeing in practices? What are the solutions, the advantages and the disadvantages to the technology? So first, introduce you and to some and to others. You know about us at the National Center for Primary Care, Morehouse School of Medicine, where we're creating the advancement of health equity. The HIT division, which houses HighBridge, is within the National Center for Primary Care. And we've been helping providers across this state, this region, and this nation to adopt digital health since about 2009. And we're still developing programs and working with the state and CMS to work with providers, but also other technology that we bring to the practices across this state. So first, a little background. We know across this world and across this nation that COVID is the main issue. You can't turn on your TV or your radio without it being taught just about COVID. And most of the news stories about this. You've seen the total deaths, which have been talked about lately at 125,000 plus. But the main thing, if you look at it, states are starting to close back down again. We're hearing that in the news because of the resurgence of the COVID virus, and also within Georgia. You know, we're one of the states, and there are hot spots. You've heard recently about Texas. You've heard about the Navajo Nation, and you've also heard about Louisiana. But of course, here in Georgia, we're also looking at the impact of COVID and how the cases are going back up. So today, you know, we're going to talk about the trends, and especially in Georgia, but we also want to say the cases have been jumping by about over 40,000. Set a record the other day of 47,000. So if you look at the graph, it's definitely going back up. But what we want to also point out is the racial and ethnic minorities who are highly impacted. If you look at the Alaska Native, they're 5.5 times higher. We've heard about African Americans who are higher, who have a higher rate of 4.5 times that of a white person, and the same thing in the Latino population. So the racial and the ethnic minority groups are impacted the most by this virus. So why? Well, there's still a lot of research to be done, and we'll find out in the future all of the factors that are causing this. But because these populations already have higher incidence of chronic diseases such as heart disease, diabetes, COPD, and obesity, they're impacted the most. And in the state of Georgia, especially with the African American population, with the higher rate of infection, but also hospitalizations and death, it's because of the underlying conditions, not just the illnesses, but also the living conditions, the inability to follow the prevention that we put forth, such as social distancing, buying the mask in some areas that are impoverished, and just the education and the training of these communities about the virus. So therefore, you have a higher impact, we believe, at this time among these populations. So looking specifically at Georgia, the rates, we've above 10,000 hospitalizations, as you see, above 77,000 confirmed cases within the state. And when we look at the number of cases over time, we can see that they continue to increase at this time. And of course, the first slide and the map that we showed you the highest impact of cases. But if we were to show you the highest impact according to race and ethnicity, you would see hot spots in such places as Daugherty County, we've heard about, around Albany, Georgia, where there have been a number of, high number of deaths and also hospitalizations related to it, and other hot spots around the state. And as you see, that our numbers also show that the African American community has a higher rate of infection and also deaths. We at the National Center for Primary Care have also done our own studies, which have been recognized in the state, and now we're looking at national data. That our data has shown that for every 1% increase in a Black population within a county or area, there's a 2.3% increase in the COVID-19 confirmed case rate, which really means the higher the percentage of African Americans within that population, the more likely you're going to have a higher rate of COVID. So it's another way to look at the higher incidence and prevalence among the minority populations. So we want to go ahead and get started because we want to hear from our panelists today. Again, we thank each of you. I'm going to turn it over to Dr. Mangia so he can kind of tell you some of his experiences, his challenges, but also he's a specialist in infectious diseases and share some of his knowledge about what's happening around the state and how it's affecting this population. Dr. Mangia, thank you.
Thank you, sir. It's a privilege to get to talk to everyone here today on this panel and be a part of such an esteemed panel. Well, I'd like to go back to March when the outbreak first occurred in the United States, or in Georgia, I would say. Obviously, there were cases in Washington in late January, but when it really hit Georgia was the very beginning of March, and that's where we really felt COVID-19 was here. I think before that, we just saw it on the news in China and the West Coast, and we didn't really think it was going to be the way it turned out to be over here. So March was a very interesting month. We had lots of cases, and we found out quickly that practices like my own practice, which is a mom and pop type of practice, and the hospitals were not prepared with the right protection, PPE. We did not have the right equipment, and nor did we understand how the virus was transmitted. And fast forward to now, we feel like PPE is more available, that the companies that are manufacturing are making PPE in abundance, so it should be available to us. And also now with social distancing and our understanding of the virus, I think we have a little bit better handle on many patients on how to test them appropriately, quickly, and then also have some sort of a treatment plan, whereas in March and April, there was no treatment plan. And probably we did a lot of the things that we would never do again, like early intubation and things like that, and not understanding that it was a thrombotic disease and not understanding that you needed to use some sort of anticoagulation. Now we know about steroids. Now the state has released through the Gilead pharmaceutical company, the state has released remdesivir for most of the hospitals to get on compassionate use. So we have a lot of things that we can use, and we have COVID plasma. So the disease has evolved quite a bit in 3 months, but there's still a lot to be learned, and there's still a lot that we as clinicians and providers and community advocates can do for our patients and each other. And I really think that one of the most important things is for clinicians is to educate our population about COVID-19, because unfortunately, some of the media channels have really downplayed COVID-19 and have made it, have given a very one-sided view about it. But it is a real disease. People are dying, and people are in need of education of it. And we as providers have to be on that forefront to help provide patients with that education. Helping people understand about social distancing, helping people understand about wearing the mask. I really am a very big advocate of wearing the mask everywhere, and I think everyone should do it. And I even thought about wearing the mask here just because I think it sets the tone that, you know, everyone should wear the mask no matter where they are. I understand if you're in your automobile or no one is around you for 20 feet, yeah, you don't need to wear a mask. But whenever you're visible to somebody, I think it's a good idea to wear the mask. Just showing them that compassionate civic responsibility that we have to one another. I want to protect you and you want to protect me. So I think it's really important to hone into patients and your clients and your colleagues about wearing the mask. COVID-19 is here to stay. Unfortunately, I think it's going to be here for the next, year, 2, 3 years. We don't know, but it's for the foreseeable future. It's here, and we're all in this together. And we all need to work together on implementing these measures, such as mask wearing and social distancing. But things are getting better in the sense that in the hospital, the death rates are declining. And that's because as clinicians in the hospital, we understand some things that we were doing wrong probably back in March and April, that we've changed our practice to, accommodate some of the things that we learned. And so I do think the death rate is better, but it's not a benign disease. And we all need to do the best to work on prevention as best as we can with our community. If there's anything else anybody would like to ask me.
Dr. Mangia, thank you so much for that and giving us, the hospital perspective, what's currently happening around the treatment, et cetera. I would like to ask you one quick question before we go to Dr. James. And this was scanned by one of the audience. How do you see the healthcare infrastructure changing from a hospital perspective? Do you see a permanent change after COVID? Do you see a structural change in the way we treat infectious diseases, but also generally how we treat things that come through the hospital doors?
Well, my personal opinion is I think that the infrastructure will change permanently for hospitals and for practices in the future. As we all know, SARS was around in 2003, and then we had H1N1 in 2009 and MERS in 2012, and now COVID-19. These infectious diseases are there. They're due to happen again. Whether it's COVID-19 or something else the next time around, this is going to happen again. And now that we've had a real pandemic, I think everybody understands the gravity. So I think you're going to see an infrastructure change in hospitals and in our practices. We're all going to have to make changes so that in 7 or 8 years or whenever the next one comes, we're prepared, and it's like the regular flu. So I definitely think that things are going to change, and this is a good wake-up call. Unfortunately, that people are suffering and dying from it, but for the ones who make it, we have to not let this happen again, and we have to learn everything we can from COVID-19 to prevent this from ever happening again.
Thank you, Dr. Mangia. Dr. James, we invited Dr. James, and Dr. James has been in practice as a pediatrician in Metro Atlanta area. She can tell you how many years. But I think what she can do now is kind of give you a practice perspective, the solo practice. Dr. Magia has his practice also, but as a primary care physician and pediatrician, Dr. James has probably had some of the same challenges and with the COVID, trying to stay in practice during the COVID as a lot of our audience. So Dr. James, can you share some of your experiences and best practices with us?
Be happy to. And I just want to thank you for having me. And as a physician, let me just say that I feel very blessed to be a physician in this era, to be hopefully a part of the solution and guide young people to become more resilient and to go on with their lives. I think each generation has challenges. And I'll just say, when I was a child, there were other infectious disease challenges. Meningitis was big when I was growing up. And as I tell my patients, I'm still here and I'm practicing as a physician. So thank you for having me so I can share my experience with this. So yes, I am independent and solo practicing. My practice is a patient-centered medical home level 3. And I'll talk about how that's really helped me to do what I do here. First of all, let me just say, surprising to a lot of my patients and my parents, I did not close my practice. And in terms of the hours of work, even though the patient volume decreased somewhat, there was always something to do. We are always in the process of trying to see what we can do better to help our patients. And so this really added on to our initiatives here. So I'll just talk about the challenges I was faced with first. And the biggest challenge that I faced was fear from patients as well as parents. It was fear of the unknown. Because we've had immunizations for a few decades, and some of the things that I saw as a child and even in my training, people don't hear about these things. They don't know about these things. They were not exposed. And I can tell you that training between Grady and Egleston Hospital, we were exposed to quite a bit. So there was this fear from the parents. A lot of the parents had fear of what to expect if they came into the practice. So as a solo office, we've always tried to practice control of infection spread. And we have some things in place to mitigate that. The children that I have come from different ethnic backgrounds. And I can tell you the fear transpired all ethnic backgrounds. My Hispanic speaking patients, the French speaking patients, all of the children had fears about what was going on. So we kept our office open. And I'll just tell you, I remember the first time I walked in fully geared up, so to speak, with one of my patients with asthma. The kid broke out crying and became pretty hysterical, even though he was wearing a mask. So I had to step back to the door and remove the mask, and he was asking me, what's wrong, where are you? And I said, I'm right here. And so I had to let him know that this was equipment, and he was okay. He was in my practice, but just seeing me with different attire on, and I'm usually in scrubs, was a little bit unnerving to my patients, the young children. Once my parents came in, I really have received a lot of congratulations from being on the front line and being open. And so just to go further into this, the other challenge that I encountered was my patient care management. Now in my practice, my largest population of patients at risk has to do with kids with asthma. I have some mental health, but majority of my patients have problems with asthma. And it's across, as I mentioned, ethnic, racial lines. So the time that this virus hit was during the time that we tend to bring a lot of our asthma kids into the office for their routine follow-ups. So we had to go use a telephone. We used our portal system to, number one, let people know we were still open, and to let them know that the child was going to be safe coming in for their follow-ups. So we brought the children in, and one of the things I found that was very surprising, even though people were, as the children would say, hunkered down during this time, many of them had taken themselves off their control medications. And instead of being well controlled, I found that a lot of these kids, unbeknownst to parents, were undergoing mild early exacerbations of their asthma. So I had to back up and do counseling, education, and just encouraging them that even though they weren't going to school, they weren't going out socializing, that they need to stay on their control of medications. The children that I follow for obesity issues, what I found, and I'm so glad I had these children to come in also, and I'm just using raw numbers, but I would just say over 90% of my children had weight gain because of eating habits. Some kids were eating out of boredom, some because of anxious concerns, hearing their parents talk about the COVID. And a lot of these children were exposed to what I would say is prolonged screen use, staying up past midnight, using screens when parents were not aware that the children were up. So parents will often ask me how much weight they had gained. So I found myself doing a lot of nutritional counseling, talking about good sleep hygiene. The kids were coming in with complaints of headaches because of, I think, not getting enough sleep and prolonged viewing on these screens. So a lot of discussion about how can we exercise? We're not going outside. My practice tends to have, I tend to have a lot of athletes in my practice and even young children who were doing recreational sports. So we had to be creative. And one of the things I told the children was that even in the house, you can run in place, you can jump rope. And I said, well, let's try this 5 minutes, 3 times a week. And every week I want you to increase it. And so just things they could do to keep their bodies moving. And then encouraging them to watch the portion size. I told one of my football players, I said, you're not working out as much, you're not training as hard. So you can't eat like you did when you were doing all of this. And so I had to encourage the patients be careful about the portion sizes that they were consuming. Oftentimes they would sneak into the pantries and eat parent snacks and grandparent snacks, and then they would come in with unintentional weight gain. The other issue had to do with my graduates who were transitioning, some into the military, some into college. And they were having issues too about not being able to go to the prom, not having a real graduation, it was virtual. So a lot of discussion with my graduates and how to transition to life after high school, as we call it, be it college or military, what kind of things they need to have in place, and just continuing that dialogue that had they not come into the office, they might have missed out on. The dental care was another challenge. Because the dental offices had closed, I found myself doing more fluoride varnishes than I typically do, and also managing kids who were waiting to have procedures done for measurement of their cavities. The wellness visits, we encouraged the parents to come in so that the children would not miss opportunities for vaccination. I actually had children who had not seen a physician at the appropriate time, as recommended by the Academy of Pediatrics, for fear that they may acquire some infection coming into the office. So I did have a few patients that I had to catch up on vaccines who had never come into my office but thought that they should wait until all of this is over. The emotional fears was another issue, especially for the younger kids. And sometimes they would just come in and just ask me how I was handling it. And so I had shared some personal information about what I was doing to stay active. And a big part of what I do is continuing to exercise and making sure that I get the type of rest that I need. But encouraging the children that as the previous doctor said, that there will be some other disease that will occur, and just sharing with them how we have evolved over years in terms of being better with our public health surveillance, developing vaccines. Hopefully we'll have a vaccine for this, and maybe a medication to stop the illness once someone acquires it. But just encouraging the young people and their parents as well, that we have scientists working on this every day. And, you know, for me, I'm very hopeful that we will have something in terms of vaccine in the very near future. In terms of the volume of my practice did dip some, but it did not completely go away. But what did go increase was the procedures that I do for my patients. So I'll just talk about the asthma patients. We do the spirometries, the asthma action plans. And so one of the things I'm glad that I stayed open, because as I told my parents, when this is over and your child is preparing to go back to school, the school nurse is going to need their plan of care for when they go back. And so we were able to continue doing the routine asthma management, refilling their medications. And what I did with my practice and changed is the length of the number of refills that I provided for my asthma patients, and providing them with the medications they would need for school, meaning their inhalers and their spacers. And what I tell the parents to do is just keep this tucked away until, you know, you register for school or whenever that starts up again. So, you know, just trying to be proactive in preparing these children for going back to school when that time comes, and providing them with vaccine records. Some of the kids will be returning back to daycare. And so in terms of the routine care, my practice, we just kept that going. Now, in terms of success, I mentioned the portal notification, the telephone calls. Often parents were really glad to hear our voice over the phone, and encouraging them that it is safe to come in to the practice to continue with their care. The practice also, as a part of the PCMH, I tend to have huddles pretty much on a daily basis, almost like having morning report. So my staff and I would get together and look at what needed to be done, who we might need to call, and what things need to be in place to make sure we were better, more efficient than before. And one of the things I found out with this COVID pandemic, the staff became more efficient. Not much wait time, because I think we had better preparation for our patients when they came in. For the younger kids, the babies, we tended to bring them in early before kids with acute illnesses would come in, and patients really appreciated that. And we still have our late night, which is Thursday. So that was available in terms of access also. Now, one of the other challenges initially was supplies, and I'm sure you all heard about this, but one of the supplies that was lacking initially was toilet paper. And fortunately, I checked my closets, and we had kind of stocked up on supplies before all of this happened. And so we did not run out any supplies for the practice. And actually, what I'm doing right now is stocking up, getting ready for the upcoming fall with PPE equipment. So in terms of revenue, I'll just talk about that. Because even though, despite the decrease in patient volume, my procedures went up. And in my practice, I tend to do a lot, I like to do procedures. So if patients had to have blood draws for whatever reason, I've always done it in my office. So the venipunctures increased, our spirometries increased, the fluoride varnishes increased. And so those are just some examples of how, despite the low volume, the procedures that generated revenue also increased. We tend to have meetings monthly with my biller, and so this went virtual. And so I was still able to get feedback from him in terms of how financially the practice was doing. And I'll just tell you this, I pay mortgage in my building. I am not leasing, and the practice was able to take part of the CARES program, but also because I am a practice owner, I was able to partner with my bank, who was very gracious with extending a grace period for the mortgage payment. And I'll just share that because I had conversation with some of my other colleagues. And so the banks were really willing to do that. In terms of other things that I noticed, I actually had patients moving into my practice from other practices who were not open. And also I noticed that I had patients come into the practice from out of state who I think were getting away from the hot spots. So in terms of volume of new patients, it increased a lot more than what I expected. So moving forward, there are platforms in terms of telehealth, which right now I am still going through a vetting process because of the type of population that I have and patients have been coming into the office. I have not had to utilize that yet. The one thing that has helped me is utilizing the system of pulling down data from other hospitals when my patients have gone to hospitals in the vicinity, especially CHOA, but I can also pull down information through the system that I was set up with through MOREHOUSE, so I can pull information and maintain continuity of care and pull those patients in who've had care access in other places. And as I said too, I felt very good about remaining open. My parents really have commended me for staying open and continuing to take care of my patients here.
Okay.
And just a little caveat that I've given to my patients in terms of prevention. And we talk about keeping the hands out of the mouth, nose, and eyes. The other thing I'm telling them to do, I've said, okay, now when you go in your house for the rest of the day, leave your shoes at the door. And I tell them to do something I did as a resident when I was training, especially in Grady. I tell them, strip down from your clothes, throw them in the hamper of the washing machine, and hit the shower. Let's not shower at bedtime. Let's do it as soon as you're in the house. And I want you to do the same thing when school starts. So just giving them some other skill sets they can do to try to mitigate spread of infection once they're in their home. And I think that about wraps it up.
Okay.
Here.
Well, thank you, Dr. James. And I have a question I want to come. We talked about telemedicine. And you shared some information with me earlier. I want to get back to that after we talked to Amin. But what I'd like to say, thank you for those practical experiences. I think I told you in our conversation, I've talked to a wide range of providers, specialists, subspecialists, et cetera, a number of practices who weren't directly to the COVID, like Dr. Mangia with infectious diseases, actually all but closed down. I actually know one ophthalmologist, he pretty much kind of just closed his practice down. And of course, the federal government was for businesses, you could get some supplements. But one thing from the National Center that we've learned that during pandemics and disasters like Hurricane Katrina and during the previous flu pandemics, minority populations, especially African-American, because that's who they had the data on in 1918, et cetera, they are at worst with their health before, during, and after pandemics. And during these times, primary care, and for pediatric vaccination is a part of it, that people will forego. So to have a practice that continues and also a model where, I don't know your final tally, but I think you shared with me that you probably didn't lose any. If anything, you sustained. The tickets were better as far as income. I think what you presented to us today is a model. So you might be getting some calls. But anyway, we'll come back with some questions. Next, I want to go to Mr. Holmes. Amin has been working, we've been partners. He's been partners with NCPC since we started on this digital health initiative in 2009, 2010. And we'd like to hear from him what he's seen from working with practices, but also he has a SOS initiative I'd like for him to talk about, which is more on the solution basis when it comes to getting data and bringing the population into this COVID education and training picture. Mr. Holmes?
Yes, thank you, Dr. Mack. I appreciate the introduction and having me today on the panel. So thank you so much for sharing this time. So a little bit about myself. I am a co-founder of SensorMed, a remote patient monitoring company. I've been a healthcare IT consultant for several years. As Dr. Mack mentioned, back, meaningful use EHR consulting, HIE, dealing with Georgia Health Information Network. I've been on the board for Georgia HIMSS. So really big in the HIT space. So I bring a little bit of a different perspective from a more technology / vendor perspective on how COVID has affected things. So just a little bit about what I've seen in the field from this perspective has been a lot of course, the wave of adoption of telemedicine, primarily the real-time video solutions, a huge uptick in that. And as a result, a lot of need for instruction, education, billing. A lot of people have never done this before, don't know about the modifiers, and they have to modify their workflow. So there's a lot of need around consulting there on how to transform their practice to take advantage of the technology and the billing, the codes that are accessible for telemedicine and remote patient monitoring. So the education has been a big part, big need with this big uptick. So everyone wants to know how it's done. The other thing too that I've been working on, and Dr. Mack is also a part of this panel, this council, is that we formed the SOS Council, which stands for Save Ourselves Council. It was prompted by this strong, I don't know exactly how to explain it, but to see the graph, the charts that you showed, Dr. Mack, at the beginning about how African Americans are affected and dying at much higher rates than other groups, it just really struck a chord with us. And we wanted to know how could we help? What can we do with what we have? And being in technology, of course, we think, okay, well, what type of technology, how can we modify our platform or get it in the right hands to be able to affect change in the right direction. So we formed the SOS Council to launch a massive data gathering effort for the African American communities across the country to identify the needs, the hardest hit areas, to be able to then route resources to those areas, whether that's in terms of isolation areas, masks, sanitizer, what have you. Then also make the case to the local politicians and press in those particular areas to let them know precisely what those community members are saying. So that initiative was launched on Juneteenth, and we're continuing to get the word out. So you can go to soscouncil.com. That's soscouncil.com, and read more about it to everyone that's on the panel, on the council. And we invite you to take the survey and help us gather this information. And it all goes towards gathering data, building heat maps, getting the epidemiologists to analyze it and make a case for these hard-hit areas. So that's a little bit about the SOS Council and my experience and the things I've been doing with the COVID epidemic from a more technical perspective. So, and I'll pass it back to you, Dr. Mack.
Thank you, Amin. Thank you so much. Thank each and every one of you. And we'd like to go into the questions. And the first question, and Dr. Manji and Dr. James, I'd like to hear from you first on this question, because we've gotten a number of questions about telehealth and how you've used telehealth in your practice. So during this COVID crisis, can you talk to that? And if you didn't, can you tell us why not, et cetera? But Dr. Manjia, since we started with you, can you kind of tell us your use of telemedicine, telehealth?
Sure. Yes, so My, patient population, unlike Dr. Steen James, is much older and more at risk for COVID-19. So we had to implement right away in March for the office-based patients and for people with COVID at the hospital getting discharged and continuing their care because their primary care physicians, many of them were not open. We had to accommodate all those patients. So for ones that we knew that were COVID positive for sure, or people that we suspected may be COVID positive, we instituted telemed medicine. And we did that by various different measures. So I noticed that a lot of the elderly patients are not very good with smartphones. Many of them don't own a smartphone to begin with. And also for some of the lower income patients, and oftentimes these are patients that are in the lower income bracket that are affected, as we've talked about here today, the African American community and the Hispanic communities. So they don't have good internet connections, and they don't have the ability to tell them, hey, download this program and go talk to you this way. So I had my office call patients on their phones, whatever contact number we had, and get in touch with patients over the phone. And I tried to do as much over the phone with as many patients as I could to keep continuity of care. Certainly there are patients that need to be seen in the office. They need an exam for whatever reason. If it's not COVID related, but they need an exam or they need something that you need to lay your eyes and hands on, that's different. But for most of the people, I did use the telephone as the primary modality. And it was very hard because we started several days before appointments, making phone calls to patients, trying to make sure that they would be available, try to answer any questions that they had about how to handle the appointment. Some patients needed translators. Luckily, in my office, I have a few people that speak very good Spanish, so we were able to accommodate those people. But I really think telemedicine is here. I think that there's a lot of opportunities to use telemedicine in more extravagant measures with smartphones and computers. But when it came upon us so quickly, the telephone really did the most help for me. And I really relied on telephone, contacting patients by phone, keeping in touch with them, and having my staff communicate with them constantly over the phone. So that's what I did. I know that a lot of doctors in the hospital that I work at, they were using other websites and other services. Some of them are free, but I just felt like it was a burden on people when they're already sick and they're already not well, to tell them to download something and then they don't have the phone or the right internet connection. To put that burden on them, I didn't think was fair. So if I had a way to get in touch with people on the phone, that was the best. If people asked me about using a particular website or FaceTiming, they had an iPhone and they said, I want to FaceTime. Yes, we did do that. But I did not put the pressure on anybody to say, hey, you have an iPhone and let's face. No, we didn't do that. We just said, we will call you, you can speak to me, and if you'd like to come in, then we instituted measures to come in. We had people come to the parking lot, we triaged in the parking lot, and we did not have people waiting in the waiting room. We had people come in one at a time, and we did those types of measures. But again, I can't say it enough, I used the phone. That was my best ally.
Okay. Thank you, sir. Thank you, sir. Dr. James, you want to comment?
Yes. As I said, kind of in the process of vetting platforms for telehealth, because COVID, as we know, is not going away. And if it's not COVID, there will be some other disease. I mean, over the years, we've seen this. I tend to think about what works for my patient population. We survey our patients to get opinions from them and to see what works. And I try to get feedback from my other colleagues as well. And what I've learned is that you have to, at least I base my practice style on the population that I serve. And I think that telemedicine for me will have a limited use. I'm very hands-on, and based on the types of patients that come in, and I think the need too for the social contact with medicine. I don't think telemedicine will take the place of the hands-on style we have now. I think it would be something that would be an adjunct for it. I think, maybe possibly for mental health type patients. And I tend to have a very low population of those. And I have colleagues who have large populations of patients with mental health issues. So it really is going to depend on the practice setting and the population that we serve. And I really don't want to be dogmatic about it, but I know as I learn and acquire more patients in my type practice and knowing what I think is best in terms of hands-on, and I think it's just my physician DNA. I have to touch kids. I tell my residents, I use all my senses for diagnosis except for the sense of taste, but kids, seeing, hearing, even the sense of smell, and all those things, touch, very important to the way I like to practice medicine. Now, I'll tell you, with telehealth, I'd love to have it so that I could have a virtual with my colleagues, my specialty colleagues, when I don't want to have to wait on paper to get a response, and just do a virtual with them and give me a heads up, what do you think? And that may be something down the road, but I don't think it's going to go away. I think as a profession, I would be mindful of making sure that if I use it, it's going to be what I think is appropriate, and not use it as a substitute for when I need to, have the patient come into the office. And
Right.
I think there's benefit, at least for young children, to see that I'm their doctor, I'm here for them, and I can listen to their concerns, and I can pick up on things that using telehealth may not address. I just think of some of the things that I saw in the office during this time, that I have seen in the office, that had I not brought him in, could have been missed. Serious things. And so,
Okay. No.
so that's my answer on that.
Thank you. And I like to point out, I think both of you point out the importance of setting. It was almost like the EHR. We thought the electronic health record was going to be, and we're advocates of that. We thought it was going to be a magic pill. We thought HIE was going to be a magic pill to solve everything. And I think it's the same thing with telehealth, especially video, because using the telephone can be considered telehealth, but the use of video in a lot of settings, like you say, sometimes the population does not have the technology, and sometimes it doesn't add any benefit. It can actually be a barrier. But in other settings, like school, we've heard, especially more rural schools, and those high-end specialties that are rare, especially in times of disasters, telemedicine. But there's still a lot of work to be done, I think, to develop systems that serve those elderly, underserved populations, those vulnerable populations. And I know Amin has been working on some of that type technology. I don't know if he wants to comment on this question or not. But no, thank you for those real perspectives, and I think that helps.
Yeah, I can add something there, Dr. Mag. I do think that, we more than any time we've seen people at least give it a try, to find out what that mix is, because until now, many places weren't forced so much, so to speak, to attempt it. And I think everyone's kind of settling in to what type of cases you can look at, or, you feel comfortable, what type of cases can provide, video can provide value, which ones cannot. And so I think, the industry is still kind of settling down and figuring out what's the best way to apply the technology. I would say quickly as well that I think the loss of volume on like a fee-for-service type of setup is also causing more people to adopt more value-based mindset. So they're thinking, which is where CMS wants everybody to go anyway, but it's more of the proactive, the monitoring, the measuring, the doing things not necessarily to a patient that's sick yet, but people are starting to learn that you can actually get revenue and be paid for doing things before they get sick. And so we've seen an uptick in that area of interest as well.
Great. Thank you. We're closing in on our time, but a couple more questions I think that we received online.
And Dr. Mack, we also
Yes.
have a few questions in the Q&A section.
Well, go ahead. Go ahead, Sherilyn.
Wonderful. Our first question to the panelists, and you can direct it as you see fit. Do you feel that there is an increase in cases because of the increase in testing availability?
Dr. Mangia, did you hear the question?
Yeah, I didn't know. Was that for me? So is there an increase of cases because of increased testing?
Yeah, do you think the reason for the increase in cases is because of increased testing?
No,
This
no,
research.
I do not think that is the case at all. And that's a common misconception. We are if we are getting adequate testing, we want to see the overall percent positives drop or go down. So we should be able to test more and more people and see that overall percentage continue to go on the decline. And in fact, it's creeping upwards. So that is a misnomer. It's a way of using statistics and talking about things to make it sound different, but that's not the case.
Thank you. Sherilyn, go ahead.
Yes, our next question. Considering the seeming benefit associated with wearing masks, why is there misinformation associated with wearing masks, and why has the usage or wearing masks been politicized?
Okay, so the mask was politicized. Well, the problem with the mask was in the very beginning, there was a shortage of masks and personal protective equipment for hospitals and frontline workers and first responders. And in an effort to preserve those protective equipment pieces, such as masks, the CDC and Dr. Fauci and other people said that we should preserve the masks for those people in those roles, first responders in hospitals. So that's where the recommendation came that it wasn't so much necessary for the general public. Once that initial surge occurred in March and April, and we got a handle on production lines for masks, and we were also able to understand that N95 mask was not required for every single person, and that we could manage with surgical masks or other cloth coverings. The recommendation then went to the full population should all use masks. So it was purely a way of, conserving resources at the greatest time of need at the beginning of the pandemic. Now the resources are available and the understanding is better. So now we will want everyone to wear a mask in any setting. And I think it's just good civic duty and responsibility as all of us in our community to one another. We all want to be well, and everybody's health depends on everybody else. So it's very important to wear the mask, not only to protect yourself, but to protect your, our community, each other. That's who, in the end, that's who we're here for, each other. So that's what it's all about. And why is it politicized or politicized? That's I don't know what to say about that. I mean, it's just I don't want to go off on that topic.
That's another webinar.
That's another one.
Okay, thank you. Our next question. How do you as clinicians and health professionals keep yourself healthy during the pandemic besides wearing masks?
Dr. Steen, James?
Dr. James, I think you had commented on that. Would you like to?
Yes, I'm happy to answer that because my parents asked me also. So in terms of mitigating illness for myself, and this is something that had nothing to do with COVID for me. So I told my parents and patients, I'm a 3 meal a day person, so I never skip breakfast, lunch, dinner, nutritious snacks, lots of water. I like to exercise. So that has benefit not only physically, but mentally and emotionally as well. So when my patients come in to see me, I'm not looking stressed. I do a routine 20, 30 minutes every morning before I come to work. I jog a couple of times a week. I'm on the tennis court a couple of times a week and making sure I get enough sleep, which oftentimes, sometimes I don't. But having balance in terms of nutrition, sleep, physical, to me makes me feel very happy when I come to work. I don't feel burned out at all because I love what I do as a physician. And then having balance outside of practice, even the spiritual component is very integral to me staying well, be it COVID or anything else.
Thank you. Thank you. Cheryl, should I just go ahead and wrap it up? I think
I think we have 1 or 2 more questions. Do you have time for 1 or 2 more?
Oh, I do.
Okay, no problem. How can health professionals or physicians use remote monitoring during this time to treat patients, whether they have COVID or whether they have pre-existing conditions which may increase their risk of contracting or having severe symptoms associated with COVID-19?
Yeah, I can take that one, Dr. Mack.
Yeah.
So with remote monitoring, there's several different different types of mobile measuring devices out there. So we have blood pressure cuffs, scales, glucometers, pulse oximeters. You name it. It's a myriad of devices available to monitor patients for various types of chronic conditions. So typically a practice would need a software platform or module for the EHR to be able to capture that type of information. You guys, what practices do get reimbursed for analyzing that information. They're typically the MAs at the office analyze it and escalate if anything weird comes across. But during the pandemic, because a lot of patients have not, the offices are closed, not a lot of people are able to come in. So we've seen a big move probably in the pressure, especially in the African American community. But there's all types of options, from scales for obesity to glucometers for diabetics. So so there's a lot of different options for practices, and we invite you to take a look at those. And this is a good opportunity. Remote patient monitoring is something.
Thank you. So we have one final question, and then I will ask each of the panelists and moderator to provide your charge for the future for our attendees or your recommendations. So our last question, with the relaxation of policies practices have moved to telemedicine solutions that are not HIPAA compliant. Are there any concerns regarding this moving forward, and what recommendations do you make for those practices who have adopted a non-HIPAA compliant telemedicine solution or virtual care solution?
Well, I guess I can chime in on that one. We take an oath to, save lives. So I would say this: if it's in the aspect of saving a life, I think you have to do it. But when you consider patient privacy, I think providers, healthcare systems should stay with HIPAA compliant technology. And that's basically it. There are legal reasons behind it, but there are also health related reasons for HIPAA laws. So I would say we should try to stay with HIPAA compliant technology. Now, whether we believe it makes the measure or not, I think that's up to the practice, of course. And there are situations where you need to use it. But there are rules and regulations from ONC about the technology, certified technology, and a practice is at risk if they don't follow the guidelines. So I would say the practicing or the health system will have to take that in consideration if they choose to use something that's not certified or something that's not HIPAA compliant.
And Dr. Mack, I just add as well is that there are plenty of options out there that are HIPAA compliant. So before the pandemic, so if you're looking for, some type of prescribing, or you're looking for some monitoring or video, there's a lot of choices out there. So you shouldn't have trouble staying within the HIPAA compliant realm.
Thank you. So I will ask each panelist and you, Dr. Mack, to provide your closing thoughts and charge forward for our webinar attendees.
15 seconds, y'all, a piece.
Okay, I'll start. SOScouncil.com. We need the data to help these communities. So please ask that you go and check that out. Also, look into your value-based revenue options in this time of need when you can service patients remotely. Thank you.
Okay, I can go next. Well, I just want to wish everybody the best. Please stay safe. Practice social distancing, wear the mask, and encourage people to get tested whenever you suspect it in your clients or patient population. I think testing is really important because if we can test and quarantine, we can definitely beat this. But we gotta get people tested, and we have to be fit through COVID. Even with some unusual presentations, COVID is there, so we have to think about it.
Okay, and I think from a pediatric standpoint, to continue to enhance preventive care, keep our patients on track, and encourage resilience as our patients age through pediatrics and transition to adult medicine. Personally, I intend to continue to be here for them as a practicing physician, and also continue to have an open mind about in terms of adapting technology to improve patient care and quality in a way that these initiatives can be measured.
Thank you, Dr. James. And I'd just like to end it by saying domestic abuse cases are up, violence is up, shootings are up. At this time, we have to be considerate of our mental health. As a primary care physician, a family physician, and whether you're a primary care physician or specialist, you have to think about your staff, have to think about yourself, but you also have to think about the patients in this population. So it's about the care, but mental health is real. So let's take care of our mental health. We thank you all. We want to thank each one of the panelists today. And we thank you all for being present. And hopefully we'll do another one in this series. You guys shared some great stuff. Invaluable. Very valuable. Thank you all.
Thank you.
Take care.
Thank you.
Thank you, audience, for being attentive.
Thank you. And on behalf of the Morehouse School of Medicine's National Center for Primary Care and Hybrid Solutions, we thank you for your attendance in today's webinar. Dr. Mack and panelists, we thank you for a highly engaging and informative webinar presentation. And for the webinar attendees, we thank you for lending your time this afternoon. Have a wonderful afternoon.